You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about LV thrombus. We'll start with epidemiology and pathophysiology, then go over imaging findings on different imaging modalities, then talk about anticoagulation agent, then anticoagulation length. Let's start with the epidemiology and pathophysiology. Before tissue plasminogen activator was available, LV thrombus complicated 20 to 60% of acute MI cases. This came down to 5% after TPA was introduced for MI, and further down to 2% after PCI became widely available. Why do LV thrombi happen? As an infarct occurs and expands, the myocardial wall thins and the damaged endothelium, with exposure of collagen and subendothelial tissue, dilates almost immediately, increasing wall stress and sometimes leading to ventricular aneurysm formation. That's the endothelial injury component in Virchow's triad. The reduced contractile function of the LV, akinesis or hypokinesis, often with a reduced ejection fraction, creates an abnormal vortex, leading to blood stasis in Virchow's triad. The exposure of subendothelial tissue and collagen to circulating blood triggers an inflammatory and prothrombotic state, which is the hypercoagulability in Virchow's triad. In addition, the low shear rate in the infarct zone activates the coagulation system by accumulation and activation of fibrin via cross-linking, the common pathway, platelets, the intrinsic pathway, and red blood cells, which comprise the fresh thrombus. On imaging, what does it look like on echocardiogram? LV thrombus on echo is seen as a discrete echo-dense mass in the left ventricle with defined margins that are distinct from the endocardium and seen throughout systole and diastole. It should be located adjacent to an area of the left ventricular wall which is hypokinetic or akinetic, because this is the region that has the slowest flow and greatest stasis. It should be seen from at least two different views. What does it look like on MRI? Since LV thrombi are avascular, they do not have any gadolinium uptake, and therefore they appear black during CMR imaging, unlike the surrounding myocardium and the blood pool, which will have various degrees of enhancement. What does it look like on angiogram? A myxoma would be vascular, so you would expect to see blood vessels going into it, whereas a thrombus would not be vascular. Can you guess the chronicity of the LV thrombus by imaging? In the acute period, LV thrombus can be classified as protuberant and or mobile. In a chronic period, LV thrombus can be classified as mural and or sessile and flat. Older thrombi tend to resemble the texture of the liver and have a smooth concave surface and tend to be less mobile. Although TEE is the method of choice for detecting atrial masses and left atrial appendage thrombi, TEE actually has low value in diagnosing LV thrombi because the apex is most often not well visualized on TE. CT has a similar specificity and sensitivity as TTE for identifying LV thrombus, but is not routinely used for this indication due to unnecessary radiation. Cardiac magnetic resonance imaging, or CMR with contrast, delayed enhancement, has the highest accuracy and is the gold standard. Cine cardiac MRI, which is cardiac MRI without any contrast agents such as gadolinium, misses almost half of the LV thrombi detected by CMR with contrast. Therefore, the 2022 scientific statement for management of patients at risk for and with left ventricular thrombus says, we suggest that cardiac MRI may be most appropriate when 1. There is the suggestion of a possible LV thrombus on echocardiogram, but echocardiography imaging even with ultrasound enhancing agent is not diagnostic, and 2. Echocardiography does not demonstrate LV thrombus, but a clinical concern remains, for example, in cardioembolic stroke. Please note there are no recent guideline documents from the AHA or ACC about LV thrombus. The closest thing that we have is a scientific statement on LV thrombus released in 2022. Therefore, you will not hear Class 1, 2A, 2B, or 3 recommendations in this episode. Scientific statements, unlike full guideline documents, do not have the ability to make formal recommendations. Let's move on to which anticoagulation agent is allowed. The 2022 scientific statement says, We suggest that on the basis of supportive, though insufficiently powered randomized data, in patients with LV thrombus, DOAC seems to be a reasonable alternative to warfarin. There is no class of recommendation for that. Traditionally, while inpatient, you would use the following. If infractionated heparin drip is used, target the PTT to the 60s, range of 50 to 70. If low molecular weight heparin, such as Lovenox, is used, dose at 1 mg per kg BID. When starting warfarin, bridge with Lovenox until therapeutic INR for 2 days. As you transition to outpatient, you want to have the warfarin on board for 3 months with target INR 2.5 and range 2.0 to 3.0. That is what is recommended by the existing statements. Newer studies are suggesting that rivaroxaban or apixaban may be acceptable as well for LV thrombus. The 2022 scientific statement says, we suggest that on the basis of consensus opinion, in some patients with persistent LV thrombus, particularly a protruding or mobile thrombus, a trial of an alternative oral anticoagulant or low molecular weight heparin is not unreasonable. For example, VKA if on DOAC, DOAC if on VKA with repeatedly subtherapeutic INR, low molecular weight heparin if on VKA with therapeutic INRs. No class of recommendation. On the other hand, also on the basis of consensus opinion, discontinuation of OAC in patients with persistent mural laminar thrombus, particularly if the thrombus becomes organized or calcified, is not unreasonable. No class of recommendation. How long should the anticoagulation keep going? Generally, after 3 months of oral anticoagulation, the anticoagulation can be discontinued if there is thrombus resolution, LVEF improves, or if there is major bleeding. However, there is no clear-cut requirement to stop oral anticoagulation at 3 months. Factors that favor continued oral anticoagulation beyond 3 months are as follows: anteroapical MI with persistent akinesis, protruding or mobile thrombus, suspected or known cardioembolic event, not high bleeding risk, pro-inflammatory or hypercoagulable states, recurrent LV thrombus on imaging. Those are the factors that favor continued oral anticoagulation beyond 3 months. How about factors that do not favor continued oral anticoagulation beyond 3 months? High bleeding risk, concomitant antiplatelet therapy, improvement in LV ejection fraction or focal akinesis improvement, persistent mural or laminated thrombus, particularly if organized or calcified despite therapeutic oral anticoagulation. The 2022 scientific statement says, we suggest that on the basis of reasonable study data, post-MI patients with LV thrombus should be treated with oral anticoagulation, typically for a duration of 3 months. We suggest that on the basis of limited data, patients with non-ischemic cardiomyopathy with LV thrombus should be treated with oral anticoagulation for at least 3 to 6 months, with discontinuation if the LVEF improves to more than 35%, assuming resolution of the LV thrombus, or if major bleeding occurs. There's insufficient study data to determine whether oral anticoagulation should be continued indefinitely. The scientific statement has 2 other statements about prophylactic oral anticoagulation prior to the formation of LV thrombus in certain conditions, but the evidence is very weak or non-existent. So prophylaxis against LV thrombus is not a fair topic for testing on a board, and I will spare you from knowing about them. That's all I have for you for LV thrombus.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.